Hi everyone, thanks for having me today. My name is Bennie Ashton, and I'm a senior data analyst at the Oklahoma Department of Mental Health and Substance Abuse Services, or ODMHSAS. So first, a little about my background. I have a PhD in quantitative political science from OU, a master's in government from UVA, and a bachelor's in political science and music from a small liberal arts college in Virginia called Randolph-Macon. So, the bottom line, I've been studying politics for way too long. And I went from studying how laws are made to working in a place where if the data is wrong, my boss definitely notices. Spoiler alert, much scarier than a professor with a red pen. Today, I'm going to talk about how data connects with behavioral health policy, and I promise no pop quiz at the end. So, what is ODMHSAS? We're Oklahoma's Behavioral Health Authority. That means we oversee mental health and substance use services across the state. That includes things like crisis centers for people experiencing immediate emergencies, prevention programs that aim to reduce substance use and mental illness before they escalate, and recovery supports to help individuals reintegrate into their communities. We work with Medicaid, federal grants, and state funds, among other funding sources, and one of our most important responsibilities is managing the 13 Community Certified Behavioral Health Clinics, or CCBHCs. Don't worry, we've got plenty more acronyms to go around. These clinics are essentially the backbone of Oklahoma's safety net for behavioral health. If someone doesn't know where else to turn, these clinics are there to serve them. Our mission is simple, but it's not easy by any means. We want to use evidence-based programs to improve outcomes for Oklahomans. And part of that evidence base is the work that my team and I do with data. So, where do I come in? My role is to make sure data informs decisions. At ODMHSAS, we have access to a huge range of data. This could be anything from claims data on services that individuals receive, which would primarily be through Medicaid. We have data on hospital and emergency room visits, calls to the 988 Suicide and Crisis Lifeline, reports on deaths and overdose-related deaths from sources like the Medical Examiner, as well as other data from partner agencies and the providers. It's a lot of information. And raw data by itself doesn't really help anyone. My job is to take all of this and translate it into insights. That could mean making a dashboard that shows real-time spikes in overdoses across the state, making a report for legislators deciding where to invest funding in overdose prevention, or conducting an evaluation of whether a new program is working as intended. In short, I try to be a bridge. I speak both SQL or SQL, which is a data language, and plain English. I can query a database 1 minute and then turn around and explain the results in a way that policymakers, clinicians, or the governor's office can actually act on. So, how exactly does data shape policy? I like to break it down into 3 steps. Step number 1, identifying needs. Where are the problems the biggest? And who is at the most risk? Step number 2, measuring outcomes. Did the program do what it was supposed to? And are people healthier, safer, and better off? Step number 3, guiding funding and priorities. Lawmakers and grant funders want evidence, and data helps to make that case. I often say our job is to answer not just the what, but also the what next. Take the opioid epidemic in Oklahoma as an example. So the what would be, over time, overdoses in Oklahoma shifted away from prescription opioids to street drugs, especially fentanyl. That's a scary trend. But identifying it is only step one. Step two is the what next. Based on that data, we can decide where to place naloxone vending machines, which communities we should particularly target to send fentanyl test strips to, and how in general to target campaigns looking to promote overdose prevention. So instead of just being a depressing line graph in a report, the data becomes a tool for saving lives. Let's look at one specific program that I've worked with called Most in Need, or MIN. Oklahoma, like many states, faced a challenge with individuals who had overlapping mental health and substance use issues. These are high-cost, high-need consumers. Providers often struggled to serve them because the costs were higher and the cases more complex. So, the state tried something other states had been experimenting with, like Colorado. We created the Most in Need program, which provides extra funding to providers who take on these individuals that are high service utilizers. But here's where data comes into the picture. My team worked to figure out among the people on the MIN list who actually benefits the most from receiving additional care coordination services, which are efforts among individuals at ODMHS to try to coordinate both physical health, mental health, community support, everything into one comprehensive basket that treats the individual as a whole. We built a statistical model comparing the people currently getting outreach through care coordination through a specifically chosen comparison group. And then through this data and our research, we found some clear patterns. Individuals that are most likely to benefit from this additional care coordination are, number one, individuals with lower levels of education. Number two, those with severe diagnoses like schizophrenia or bipolar disorder. And number three, people with both a serious mental illness and a substance use disorder. And we were able to identify these individuals using demographic data and service data from our databases. Those groups were the ones who got the biggest benefit overall from additional care coordination services, which means we can now focus resources on them instead of just spreading our services very thin across everyone. That's the value of data in policy, not just funding a program, but making sure the program is targeted and effective. So here's what I want to leave you with. Policy work isn't abstract. It's not just bills, statutes, or grant language. It's about real people, and data is one of the ways we connect the dots between policy decisions and individual lives. A common misconception is that data careers are about coding or technical skills. Don't get me wrong. I enjoy my little toys like R and SQL or Excel as much as the next data nerd. But if you stop at the code, all you built is a flashy dashboard that nobody uses. The real impact comes from being able to translate those numbers into stories and next steps. Policymakers need to understand the what, but more importantly, they need to know the what next. That's the key skill I'd encourage you to think about no matter where you end up in data, policy, advocacy. Being able to communicate evidence clearly in a way people can act on is how you turn information into change. Thank you all so much for your time. I'd love to take your questions or comments. Just please, no questions about my coding bugs. Those are still unresolved. I'd rather not relive those in public. Joking aside, though, I also have a slide here with my email, my LinkedIn, and a couple of additional resources if you want to learn more about the vending machines project, ODMHSAS, or 988. Thank you very much.